Okay, so let's start. Good morning, everyone. So before we start our lecture on this topic, let me ask someone na mag-lead sa atin ng prayer. Thank you.
Good morning, Doc. I will lead the prayer.
Okay.
Let us turn to God with hearts filled with gratitude and praise. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. When we live in unity, how good and how blessed it is. Pray for us, Holy Father Saint Augustine, that we may
dwell together in peace.
Let us pray. O God, our
God
Father,
our Father, your Son promised to be present in the midst of all who come together in His name. Help us recognize His presence among us and experience in our hearts the abundance of your grace, your mercy, and your peace. In truth and in love, we ask this through Christ our Lord. Amen.
Lord, amen. Our Lady of Good Counsel, pray for us. Lord, lead ourselves. Our heart is
restless until it rests in you.
In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Okay, so good morning, everyone. Again, so this is the second topic for our end terms. This is entitled Non-Protein Nitrogen. I hope you can see my slides. Can you see it?
Yes, Doc.
Yes, sir.
All right, sige. Let's start off. So for our learning objectives are the following. Okay, so let's start off with non-protein nitrogen. What is non-protein nitrogen? So from the word itself, alam na natin, non-protein nitrogen. These are nitrogenous substances that is devoid of urine. Kasi originally, during sa mga olden days, ang ginagamit nilang before they measure non-protein nitrogen, they used to remove the protein from the sample, and then subsequently acted upon by your Nestler's reagent to produce a yellow color. That's how they produce, or that's how they measure the non-protein nitrogen. So they need to separate first the protein from the sample so that it would be acted upon by the Nestler's reagent, which will yield your non-protein nitrogen. Now, this yellow color can provide accurate determination of the total NPN concentration. So, luckily, nowadays, hindi na natin ginagawa yung magse-separate pa ng protein and then i-test agad yung non-protein nitrogen to check on the NPN concentration. Ngayon, mayroon tayong methods that could, kahit walang separation of protein, we can measure the non-protein nitrogen right away. So remember that non-protein nitrogen, there are different substances, including the non-protein nitrogen fractions, and usually most of them is used to monitor and assess renal function, okay, except for one, which is your ammonia, more on the liver function yon. Okay, as I have mentioned earlier, so the NPN fraction comprises of not just these are the most common, but it also contains, or it also includes 15 compounds of clinical interest. However, during our discussion, ito lang yung mga i-measure natin or i-discuss natin sa araw na ito. Okay? And the majority of these compounds arise from the catabolism of proteins and nucleic acids. Okay, so we have already discussed amino acids and your proteins. And ito yung majority of the clinically significant NPN compounds, of which urea is siya yung pinakamarami, approximately 45 to 50%. Okay, amino acids and your creatine are not present in the urine, or very, very minimal concentration in the urine, because they are useful to the body. They are meron tayong amino acid pool, and creatine is very important in your muscle metabolism. All right, so nagagamit sila, so they are in constant pooling of the body. Next is your uric acid. All right, creatinine, your creatine and your ammonia. Remember that the ammonia, the percent concentration of ammonia in the plasma is very minimal. Why do you think? Why do you think that the ammonia is the the least of all, or pinaka-konti siya na concentration? Anyone? Oh, very good, because free ammonia is highly toxic, and therefore it is converted into a less toxic substance. Pwede siya ma-convert to urea, di ba? The urea cycle, so that can be excreted to the body. Okay, yun na yun. All right. So next is the first NPN we're going to discuss is your BUN or yung urea. So commonly termed as BUN, di ba? Or blood urea nitrogen. So it is read as BUN and not BUN, okay? So it is the highest concentration of NPN compound in the blood, all right? And it is the major excretory product of protein metabolism. So partly of urine metabolism, there are ammonium ions that is produced, or ammonia that is produced, which are further detoxified in the liver to produce your urea. So any protein metabolism, meron tayong excretory product, which is your urea. And remember that it's formed in the liver from amino groups, okay, NH2 and free ammonia generated during protein catabolism. Okay, so this is the structure of your urea. Okay, meron tayong carbon, hydrogen, oxygen, nitrogen. Okay, remember, di ba, itong CHON, ano pa nga yung structure, ano pa nga yung molecule that is this of similar compositions or components? Can you recall?
Protein, sir.
Correct. Okay, very good. Protein, di ba? May carbon, hydrogen, oxygen, nitrogen, may sulfur, okay? Chon. Kaya pag ginasulat na ganit sa, di ba? Chon or chons. Okay? Also remember, ito yung ano niya, meron siyang central carbon pero meron siyang amino group on both sides. Tapos meron siyang double bond to your oxygen molecule. Okay, how different is the structure of urea from amino acid? Who can recall? Okay, anong pinagkaiba ng urea from an amino acid, which is the building block of your proteins? Anyone? Ano ba yung component ng amino acid natin?
The presence of amino group.
Okay, mayroon tayong amino group. What else?
Carboxylic acid, carboxylic group.
Correct. And meron siyang...
And then the R.
Yes, meron siyang R group. Yes, meron siyang R or functional group which is unique to a specific type of your amino acid. All right. So, following synthesis in the liver, okay, urea is carried in the blood to the kidney. Okay, kasi lahat naman nasa blood man yan, dissolved in the plasma. Okay, and most of the urea actually is in the glomerular filtrate, is excreted in the urine. So majority, kasi since this is a waste product of your protein catabolism, it is excreted majority in the urine, although some is reabsorbed. Around 40% of urea is reabsorbed. Remember that this is a sensitive marker of renal glomerular filtration. However, in conjunction to other NPN or other tests natin, ginagamit sila in conjunction to each other so that it could yield a better, a more comprehensive assays or results. Okay? Remember that the concentration of urea in the plasma is determined by the following factors. Kaya although it is a sensitive marker, hindi siya masyadong kung solely gagamitin siya, no? So it can be affected by the following. We have the renal function and perfusion. Okay, pag sinabing perfusion, more on the blood volume ito. All right? The protein content in the diet, although hindi naman talaga although yung fasting na urea is not required and a single fasting meal, hindi din siya mag-effect or mag-affect sa result natin. So protein content in the diet and the rate of protein catabolism. So remember your nitrogen balance, di ba? Okay, pag more than, ano yung, what do you call, or what is the nitrogen balance when the protein catabolism is more than or greater than the anabolism? Is it a positive or is it a negative? Catabolism is more than or greater than the anabolism. Can you remember?
Less, sir.
What?
Mas less.
Oh, is it a positive nitrogen balance or is it a negative nitrogen balance? Okay. Sige. Assignment later, it will come out in the exam or in the quiz. Okay, recall nyo yun ha? Okay. So ito yung pathway natin ng urea natin, all right? So dietary protein, okay, of course, it will be degraded into amino acids. Remember your protein digestion. So although we have endogenous protein then that is pwede silang mag-interconnect or pwede siyang yung pathway ba niya kasi meron tayong de novo na protein synthesis din, no, based on the our previous discussion on amino acids. We have essential and non-essential. So meron tayong de novo na napoproduce yung amino acids within the system. And then when there is amino acid metabolism, that's the time when we have the non-protein nitrogenous compounds. And during the amino acid breakdown or during the amination, of course, NH2 amino group is liberated and it is converted into urea via the urea cycle. All right? And then your carbon skeleton, again, meron tayong mga amino acids na glucogenic and from fats, okay? We have glucogenic and ketogenic amino acids which can be used further for the energy consumption of the body or of the cells. All right? So, can you give me the answer to this? Kasi sabi natin urea is affected by several factors including your perfusion. So for example, in patient with oliguria or anuria, ibig sabihin konti yung urine output niya or wala na talaga siyang urine output. What do you think is the blood urine nitrogen? Is it increased or is it decreased? Or just decreased? Okay. Who can volunteer? Oy, very easy yan ha. Okay lang. Pag wala kang urine output, so may sira yung kidney mo, so what do you think is the blood urea nitrogen? Mataas ba sa dugo or mababa sa dugo?
Increase, sir.
Let's see. Okay, correct. Increase. Okay. Okay, increase kasi sira na yung ano mo sira na yung kidney mo. So hindi mo na-excrete properly yung blood urea nitrogen. How about high protein diet? What do you think? Okay. Do I have to call or can anyone
Increase, Doc.
Increase, correct, increase. Although fasting urea is not usually done, nag-increase pa din naman talaga yung high protein diet, yung BUN natin. All right. Although a single instance lang na nag-fast ka, it will have no significant effect din naman. How about protein catabolism? So mabilis yung pag-degrade ng protein mo, mabilis na nagamit such as stress, for example, in burns, in high fever, starvation. What do you think?
Decreased, Doc.
Decreased? Increase kasi remember that urea is urea is the product of protein metabolism, so including that your catabolism. So mabilis yung pag-degrade ng proteins mo, waste excretory products. Expected natin is still okay, increase. How about shock or heart failure? Remember, pag may heart failure, hindi ka makakapag-pump ng dugo into the vital organs, including your kidney. So mababa yung perfusion mo doon. So kung konti lang yung dugo or plasma flow na pumupunta sa kidneys, what is expected of the BUN?
Increased man, Doc.
Correct. Okay, very good, increase, right? So this is the pathway of the urea excretion cycle. So ito na-mention ko na din kanina, no? Protein, amino acid, the ammonia will be recycled or be converted to the urea in the liver, all right? And 90% excreted from the kidney, although my 10% or some concentration of it is actually excreted also in the GIT and again reabsorbed back into the system. And ito yung 90% excreted from the kidney, majority of which in the urine, syempre. All right? So what do you think are the clinical applications of your urea? So the measurement of urea is very useful to, number one, evaluate renal function. Although as I have mentioned, yung mga NPN natin is used in conjunction with other non-protein nitrogen, okay, to assess hydration status. Actually, this is matatakal natin ito sa kidney function, no? And also to determine the nitrogen balance, okay, whether positive or negative nitrogen balance. It can aid in the diagnosis of renal diseases or the location kung saan yung abnormalities natin, okay, in conjunction with your creatinine, and to verify the adequacy of dialysis also in conjunction with your creatinine. Usually pre and post dialysis, meron tayong urea concentration na nire-require sa pasyente. All right? So what are the methods of your urea? Okay, assays for urea were originally performed on a protein-free filtrate, as I mentioned earlier during the times, no? And based on the measurement of the amount of nitrogen in the sample. So urea is often reported in terms of nitrogen concentration rather than the urea concentration. Kaya that's why pag nagpa-test tayo, anong i-test mo? BUN. So hindi natin sinasabi na urea. Although sa atin, alam natin that is also BUN. All right? Pero commonly, it is reported as the nitrogen concentration. So BUN. And remember the conversion factor, which is 0.357 or 0.36, no? So this is how we derive BUN to urea. Okay, this is the formula. And remember the conversion factor and also the reference values. So what are the methods of your urea? Okay, again, as I have mentioned, the nitrogen rather than the urea concentration is being reported, and we have two methods. Also, it is also parehas lang din ito sa ibang non-protein nitrogen natin. Okay, we have the direct and the indirect. When we say direct method, wala na tayo na kailangan pang enzymatic hydrolysis. So therefore, walang enzymes involved in direct. It is a chemical method. Chemical hydrolysis yung ginagawa. Okay, very simple, no? Ilalagyan mo lang ng chemical, yun na yun. While for indirect methods, we use enzymes, and the enzymes used is your urease. Okay, so indirect siya kasi kailangan mo na siyang i-convert. Kailangan mo nang i-convert yung urea. Okay, and with the action of urease, urea is hydrolyzed, causing the liberation of your ammonia, and then itong ammonia is measured, okay, by either necellularization, Berthelot reaction, or acid titration. Remember that the indirect methods, ito yung ina-adapt natin sa automation, and it is the most frequently used in most clinical laboratories. And we have the different indirect methods. Sa direct methods pala muna, okay? Sa direct methods, as I have mentioned, walang involved ang urease or walang enzyme, correct? So first is the Fearon reaction or the DAM method, diacetyl monoxide method, in which urea, in addition to your DAM, will produce a yellow diazine derivative, which is monitored using the fluorescent compound monitored spectrophotometrically at these nanometers, at this wavelength, no, 550 nm, 415 nm. All right. Next is your Santidrol reaction, in which the urea reacts directly with the Santidrol to form disantidrol urea, causing turbidity, and again measured photometrically. So remember, walang enzyme involved. Okay, next we have your indirect methods. Indirect methods to hindi ko lang na ano. Okay, first is your Ano nga ba pag indirect methods? Indirect, meron siyang enzyme. Alright? So urographic method first, urographic method or the Conway microdiffusion. Actually, yung Conway microdiffusion, this is also used from sa ibang non-protein nitrogen natin, nitrogen compounds. Alright? First is your Conway microdiffusion. Remember, this is based on the acid titration and it uses a urastrat strip. Later, I'm going to show you anong itsura noon. Kasi ito yung pinaka-old, ito one of the oldest methods ito, no? Urea is measured by measuring the height of the blue color secondary to capillary action and the chemical reaction sa strip. Alright, so this is how it is derived. Height times 5 plus 10. Then you will have the concentration of BUN in milligrams per deciliter. Next is your Van Slyke-Cullen method, in which it is used in the urea determination present in your urine. So that this is how it is done. So ammonium salts are removed by treating the urine with permutate and ammonium-free solution and then subjected to your sodium hypobromite in the vacuum, also known as your Van Slyke CO2 apparatus. Okay, so this guy is in love with you, pare. This guys is this is the Conway microdiffusion. Okay, so ito yung urograph method natin. Okay, so all you have to do is you need to have at least 0.2 ml of serum in a test tube, and then ilalagay mo lang ang strip, ang urostrat strip. Okay, and then by capillary action, itong strip natin has different regions and different components, no? First is we have the urease, we have the potassium carbonate and a plastic barrier, and then tartaric acid with indicator. So anong mangyayari? Okay. The serum, pag by capillary action, pag umakyat siya dyan, of course, kung merong urea, okay, it will be broken down by your urease and then producing your ammonia. And then yung potassium carbonate will release the ammonia as a free gas. Okay, then the ammonium gas or the gaseous ammonia will migrate further into the topmost part of the strip, and it will convert or it will convert your indicator from green to blue with the action of your tartaric acid, which is also a trap for the gaseous ammonia na hindi siya further volatile, mag-evaporate. All right. So itong height na to, as I mentioned earlier, yun yung measurement niya, and depending on the blue or the intensity of the blue color, it will also signify the concentration of your urea. All right, aside from that, we also have, as I mentioned, no, urea and the indirect methods in automation, kasi ito talagang ginagamit din natin sa mga clinical analyzers namin. First is the measurement of NADH consumption. Again, the product, the NADH is measured, the absorbance, all right? And it is usually seen in your DuPont ACA analyzer. Next is your conductimetric. Okay, pag sinabi ng conductimetric, meron niyang electrode, which measures the conductivity of the mixture where ammonium ions and bicarbonate are generated, again by enzymatic action. And this is the principle applied in your Beckman analyzer. Next is your use of ammonia sensing electrode. Okay, so an immobilized urease, again, merong urease kasi indirect, di ba? On an inert column, releases the ammonia, which is eluted and measured by ammonium sensing electrode. Okay, so before we measure urea, what are the specimen requirements? So remember that urea can be measured in the plasma, serum, or urine. All right. However, in practice, no, parang serum naman talaga yung ginagamit. Kasi if plasma is collected, it should be noted that ammonium ions and high concentrations of sodium citrate and sodium fluoride, which are your anticoagulant, it should be avoided kasi it will inhibit your urease. All right. Next is your fasting sample is not usually required, as I have mentioned, although it can be affected by a high protein diet, pero usually in a long course. Okay, pag isang beses lang, it will not have a significant result or affectation on the result. Next is Very common to all analytes, no? Non-hemolyzed sample is recommended, all right? And then urea is susceptible to bacterial decomposition by urease producing bacteria. So samples, particularly in the urine, that cannot be analyzed within a few hours must be refrigerated. Okay, so take note on that, guys. All right. So these are the reference intervals. Okay. Please take note. Also, nandyan man sa notes natin. Okay, so when we say urea, the clinical conditions associated with your urea, first is your azotemia and uremia or uremic syndrome. Anong binagkaiba nila? Pag sinabi natin azotemia, this is an elevated concentration of urea in the blood. Alright, so mataas yung urea mo sa blood. Ano naman yung uremia? Mataas din ang concentration in the blood plus meron kang renal failure. So ibig sabihin, yung uremia natin is azotemia plus renal failure. And remember that uremia is very fatal without management or without intervention, which is in the form of your dialysis and or transplantation. So di ba pag nakikita natin yung mga uremic patients, mga dialysis patients, usually ito yung mga manifestations nila. So Sodium retention and volume overload, may edema, all right? May hyperkalemia, so they are at risk of pwede silang magkaroon ng arrhythmia, metabolic acidosis, increased phosphate, so pwede kang decreased calcium, okay? Meron tayong calcium and phosphate derangement, all right? And we also have anemia secondary to, di ba, yung erythropoietin natin is from the kidneys. So very widespread yung effect ng CKD, okay? Sometimes may affectation din sa skin, parang bronze colored na siya, di ba? So makikita na, malalaman natin yung mga patients, mga dialysis patients with these signs and symptoms, and they need to have dialysis talaga. Okay, depende on the level of the urea or the level of the NP and urea creatinine, no? Sometimes 2 to 3 times a week, ganon, all right? So, what are the causes of abnormal plasma urea concentration? Now, with increased concentration, remember that azotemia can be classified according to the the timing or the state kung saan sila nagkukos, okay? Kung saan sila nagkukos, whether pre-renal, renal, or post-renal. So, lahat ito nagkukos ng increased urea concentration. First is pre-renal. Ibig sabihin, before pa napunta sa kidney, okay? So, ibig sabihin, this is mostly due to reduced renal blood flow, okay? And that includes the following, as I have mentioned earlier, congestive heart failure, okay? Hindi makakapag-pump yung heart mo, kaya konti lang yung renal perfusion mo. Also with shock, for example, meron tayong cardiogenic shock, ganun din. Yung pump, yung systolic pressure or systolic function ng heart mo, hindi maganda. Or also from hemorrhagic, okay? Meron ka nasagasaan or may nasagasaan, hindi ikaw nagsagasa. Kung merong nasagasaan, for example, and there is hemorrhagic shock, so wala kang blood volume enough to perfuse the kidney, so that can cause an increased urea concentration. Same as your dehydration, an increased catabolism, increased protein catabolism. So ito yung kanina natin, no? Increased catabolism. Siyempre, increase yung degradation ng protein mo because urea is the end product of protein catabolism, protein metabolism, and also high protein diet. Now, when we say renal or intrarenal, of course, the problem is intrinsic to the renal parenchyma or the renal tissue. So usually this is due to decreased renal function that cause compromised urea excretion. So hindi mo na ma-excrete yung urea properly. So this can be seen in your acute and chronic renal failure and other renal diseases, including glomerulonephritis and also tubular necrosis. Ang tubular necrosis, usually ito yung mga poisoning, no? Yung mga substances that cause pwedeng oxidative or pwedeng hypoxemic or hypoxia to the renal tubules that cause tubular necrosis or other substances that are nephrotoxic. Pwede yun. Alright? Next is your post-renal. Ibig sabihin, after na siya ng pag-flow ng urine, after na siya sa kidney. So, ibig sabihin, this can be due to the obstruction of urine flow anywhere in the urinary tract. So, outside the renal parenchyma na siya. So this can be due to the following, no? We have renal calculi, okay? Hindi pwede yung nephrolithiasis kasi nephrolithiasis, renal yon, intrarenal yon. Ito, pwede din pala, renal calculi and also tumors, usually sa bandang distal na to. So probably sa renal pelvis, okay? Outside na siya. So yun, sa renal pelvis na siya, going na yung sa pathway ng urine ba, going to the bladder. And also tumors of the bladder or prostate or severe infection can also cause your post-renal azotemia. And also we have the decreased concentration of your urea in the plasma, and that includes the following. We have low protein intake, severe vomiting and diarrhea, liver disease, hindi ka makakaproduce ng urea, okay, from ammonia, and late pregnancy and infancy. So why is there decreased urea pregnancy? Why is there decreased urea concentration in pregnancy and also in infancy? Why do you think? Ano kaya sa pregnancy tsaka sa infancy? Okay, sa mga developing child. Why do you think that the plasma urea concentration is decreased? Anyone? This is something to do with your nitrogen balance. Okay? Ayan na, may ano na kayo ha. May ano tawag, may choice, may ano na kayo, may hint na kayo. What do you think? Ano, magtawag ba ako? Anyone? Sige, Siret. Okay. This is going to be ano yan? Kasama ito sa quiz natin. Assignment nyo na lang yan, ha? Alright, so why is there decreased urea concentration in pregnancy and in developing children or infancy? Alright? Okay, so with regards to, as I mentioned earlier, usually urea is done in conjunction to your creatinine because it is very important for us to know whether it is anong cause ng high urea concentration. So mas malalaman, mas mapipinpoint natin kung saan itong galing, kung ano yung cause nito. Okay? Pag pre-renal, usually high urea and normal creatinine. Alright? And usually, so based from the urea creatinine ratio, urea over creatinine, pag mataas yung urea, usually high yung UC ratio natin. And remember, this is the normal urea creatinine ratio, 10:1 to 20:1. While your renal azotemia, usually low urea and normal creatinine, so therefore low yung urea creatinine ratio mo. Although this can also be seen in condition with decreased urea production such as low protein intake, acute tubular necrosis, and also severe liver disease can also be seen in such cases, no? And lastly, your post-renal, usually high urea and high creatinine causing a high UC ratio. All right. So next, NPN is your uric acid or mas kilala bilang blood uric acid or BUA. Okay, BUN, kanina ito BUA. So remember that BUA is a product of catabolism of purine nucleic acids, adenosine and guanine. Okay, remember your DNA, okay, deoxyribonucleic acids, no? Your nucleic acids in general. So we have purine and pyrimidine, no? So most uric acid is reabsorbed 98 to 100% in the proximal tubules and reused. Kasi importante yung uric acid in purine metabolism. So kailangan isa-salvage ito, sinisave ito for further use. Okay, so remember that uric acid is relatively insoluble in plasma with a pH of 7. Okay. And at high concentration, it can be deposited in the joints and tissue causing painful inflammation. In severe cases, it can cause your gout. All right, your gouty arthritis. And also, pag acid yung environment niya, the uric acid will crystallize in the form of your uric acid crystals. I'm sure alam niyo na ito sa clinical microscopy natin. So remember that the solubility of the uric acid is dependent on the pH of the surrounding or the environment niya. So pag base or pag neutral, hindi siya mag-precipitate. Pag acid na, tsaka siya mag-precipitate. Okay? Or tsaka siya mag-crystallize. All right? Very clear on that. All right, what are the clinical applications of your uric acid? So saan ginagamit? First, it is used to assess inherited disorders of purine metabolism, okay, to confirm the diagnosis and monitor treatment of gout, to assist in the diagnosis of renal calculi, okay, specifically your uric acid stones, to prevent uric acid nephropathy during chemotherapeutic treatment, and to detect kidney dysfunction. Okay, to assist diagnosis of renal calculi, not just uric acid, because some of the calculi actually are a mix or a combination of different substances or different stones, no? Meron pa ding component na iba, all right? Okay, next, my question is, why is there increased uric acid in cancer patients after chemotherapy? Kasi yung clinical application ng uric acid natin is to prevent uric acid nephropathy during chemotherapeutic treatment. Bakit meron tayong mataas na uric acid in cancer patients after chemotherapy? What do you think? Anyone? Ay, sorry. Ano, magtawag ako? Sige, magtawag ako. Lloyd. What do you think, Lloyd?
Sorry, sir. Wala ko idea, sir.
Okay. Kasi sabi natin, di ba, uric acid is a product of your purine metabolism. Purine is present in the nucleic acid sa DNA natin. And DNA is present in the cell. Okay? An integral component of your cell. Okay? So, further. Can I call sino ba? Okay. Okay, sino? Ayan, meron na. Who can answer? Actually, I already mentioned na din no?
Lysis, sir, sa mga cells, sir.
Okay. Okay, very good. All right. So, that is due to kasi post-chemotherapy, nagbigay ka ng chemotherapeutic agents attacking the highly proliferative cells, and the highly proliferative cells are lysed, are destroyed, therefore releasing the purines and pyrimidines from the nucleus, and therefore with the purine metabolism or purine catabolism will cause the increase in your uric acid. All right. So we have the methods in uric acid. So first we have redox or non-enzymatic and the enzymatic. So ganun din yun, parang direct and indirect, just like your urea. So pag non-enzymatic method, this uses phosphotungstic acid, which will reduce your uric acid in an alkali medium to form the allantoin, carbon dioxide, and blue phosphotungstate complex. And several adaptations are actually done, no? Include the Follin, Brown, Benedict, or Newton. And also, some methods can also utilize sodium carbonate, okay, instead of your phosphotungstic acid. Ito yung Caraway, Archibald, and Henry. All right. And next is your enzymatic. Again, okay, it is used to catalyze the reaction of uric acid by uricase. And usually uricase is extracted from this microorganism, Bacillus fastidiosus or Candida utilis. Okay, other enzymatic methods include your differential UV absorption, okay, which is based on the principle that uric acid has a maximum absorbance of 290 to 293 nm compared to your allantoin, all right? And also coupled uricase reaction. So coupled, kasi dalawa, no? The hydrogen peroxide produced in the enzymatic reaction is coupled with your enzyme peroxidase. So uricase and then peroxidase, all right? Next is your uricase-Hans reaction, in which hydrogen peroxide produced is used to oxidize methanol to formaldehyde. Other other methods include your polarographic uricase method, in which the oxygen consumed during enzymatic reaction is measured by an oxygen sensing electrode. And also the proposed reference method for this for BUA is your isotope dilution mass spectrometry, or IDMS. This can also be done in other NPN compounds. And another method is your spectrophotometric. Okay, what about the specimen requirements for your uric acid? So we have, okay, kailangan natin ng non-lipemic, non-hemolyzed, non-ecteric, heparinized plasma. Okay, or serum. Usually stable ang serum eh. Pag i-ref natin siya, okay? Pag na-separate agad yung serum from the red cells or the cellular components. Or it can also be used in the urine, okay? Serum should be separated from cells soon after collection to avoid dilution. And again, just like urea, fasting is not a requirement. And remember also, potassium oxalate is contraindicated kasi it can cause a disruption in the redox method. So usually kasi pwede siyang maging reducing agent or oxidizing agent siya. So affecting the redox potential. Okay? And also, because it can promote turbidity. Remember that you need to avoid EDTA or fluoride in using uric acid. So ang pinaka-safe talaga na sample, or most commonly done, is your serum. All right? Urine specimens must be alkaline or alkaline at pH of 8 kasi para hindi siya mag-crystallize ang uric acid. All right? Starvation, high protein-rich diet, stress, alcohol abuse increases blood uric acid level, while these substances, acetaminophen, ascorbic acid, and levodopa, produces false elevated value in colorimetry kasi it can alter or it can affect the redox, most especially the redox methods. And aside from that, aspirin in high doses decreases the level of your uric acid. So remember, these are the reference interval, no? The conversion factor for uric acid from milligrams per DL to millimoles per liter is 0.059. So for uniformity sake, ito yun ha. Okay, 0 tuloy para ilunggo ka to. 0.059. All right, and these are your reference intervals. So magkaiba sa male, female, child, and in general adult. Okay, and while your non-enzymatic endpoint analysis are the following. This is also in your notes. Okay, so what are the causes of normal plasma uric acid concentration? First, we have the increased concentration or hyperuricemia. Remember that very complicated kasi yung purine pyrimidine pathway. So lahat ng enzyme deficiencies associated with the salvage pathway of your purine and pyrimidines are included in these conditions that can cause an increase or hyperuricemia. So first, we have the Lesch-Nyhan syndrome, HGPRT deficiency, hypoxanthine guanine phosphoribosyl transferase deficiency, the PPRS deficiency, phosphoribosyl pyrophosphate synthetase deficiency. We also have glycogen storage disease type 1, fructose intolerance. Aside from that, we also have gout. Okay, treatment of myeloproliferative diseases with cytotoxic drugs, as we have mentioned earlier. No, hemolytic and proliferative processes. So hemolytic, destruction of the cells, release your pyrimides and your purines. All right. Chronic renal disease, toxemia of pregnancy, lactic acidosis, drugs and poisons, purine-rich diet, increased tissue catabolism or starvation can also increase your plasma uric acid. While your decreased concentration or hypouricemia can occur in cases of liver disease, defective tubular reabsorption, so hindi na reabsorb, na-excrete siya, kaya mababa yung uric acid natin. Chemotherapy with azathioprine or 6-mercaptopurine because they act as a competitor with your usual purine, and overtreatment with allopurinol. Hala, inom ka ng inom, ginawa mong vitamins o allopurinol, so wala ka ng uric acid. All right? So next is your I'll give focus to the Lesch-Nyhan syndrome kasi very common ito. Pag sinabing blood uric acid, kahit nakapikit ka, Lesch-Nyhan syndrome. Ano yung Lesch-Nyhan syndrome? This is an X-linked genetic disorder seen only in males, or they manifest in males because the male chromosome is XY. So abnormal yung X mo, wala ka ng reserve na another X, just like in female. So it will manifest. So it can cause the complete deficiency of your hypoxanthine guanine phosphoribosyl transferase or your HGPRT. Ito yung number niya sa enzyme classification, no, sa nomenclature. This is an important enzyme in the biosynthesis of proteins. This is the salvage pathway. Pag sinabi ng salvage pathway, is-save yung mga purines or pyrimidines na na-release sa blood, okay, para magamit ulit. So, manifestations include neurologic symptoms, mental retardation, and self-mutilation. So, self-mutilation, sometimes nginangat-ngat mo yung mga daliri mo, yung labi mo, yung bibig, ganyan yung itsura niya. Okay? So, aside from the neurologic symptoms such as mental retardation, ganon yung characteristic ng Lesch-Nyhan syndrome. So kayo, pag nagakaon-kaon, nagakit-kit ka mo sang inyong kuko, okay, magpa-check na kamoy ng uric acid nyo. Alright? So next is your gout. Pinakakilala na gout. Our parents might have gout na din siguro. So gout, naalala ko yung Iranian ko na classmate sa una, goat yung sabi niya, goat siya ng goat. Okay? Bahala ka, basta correct yung pagsabi, correct yung spelling mo, okay? Gout is a disease found primarily in men and usually first diagnosed between 30, okay? 30 to 50 years of age. And remember that the affected individuals usually have a painful inflammation of the joints secondary to the precipitation of monosodium urates. Remember also na nandito or na-discuss din ito sa clinical microscopy nyo. Alright? So usually merong hyperuricemia in half or one-fourth of the patients, causing 6 milligrams per DL or greater of BUA. Okay, and in severe cases, as I have mentioned, deposit of crystalline uric acid called tophi could deform the tissue, causing deformity. So ito yung mga tophi natin, no? Matitigas yan, no? Sometimes they are mistaken as tumors or soft tissue tumors of the joints. So remember that this is exacerbated by high purine diet, so for example, or alcohol, no? So ito yung mga high or protein-rich diet natin na dapat iwasan nyo, alright? Seafoods, okay? And also meats, no? Liver, sweetbreads, turkey, Diyos ko, ano pang kakainin mo dyan? Asparagus, mga maaarte man to na food, no? Mushroom, peas, lentils, spinach. Anyway, yun yung mga seafood, mga lamang loob, alright? So, iwas tayo dyan so that hindi tayo magkaroon ng risk for developing gout. Next is your creatine and creatinine. So first we discussed, because they are interrelated, no? What is creatine? Creatine is synthesized mainly in the liver from arginine, glycine, and methionine. Okay? It is transported to tissues like muscles and converted to phosphocreatine, which is a high energy source and is used to monitor muscle disease using creatinine kinase. Kasi directly, hindi na ito minimeasure yung creatine using direct method. Okay? Yung ginagamit na natin yung enzyme kasi mahirap siyang i-measure on its own. Okay? Next is your creatinine. Creatinine is formed from creatine and creatine phosphate. Kaya interrelated siya kasi galing doon si creatine. It's either creatine can be converted into creatinine itself, or creatine can be converted into phosphocreatine. Okay, and phosphocreatine can be converted back into creatinine. Okay, later I'm going to show you the figure. Okay, it is excreted in the plasma at a constant rate related to muscle mass. Okay, usually kung ayun nga, this is proportionate to your muscle mass. All right, plasma creatinine is inversely related to glomerular filtration rate and is commonly used to assess renal function. So inversely related, ibig sabihin if your plasma creatinine is, or ibig sabihin, if your glomerular filtration rate is mababa, okay, so inversely, so therefore the plasma creatinine will be increased, okay, and vice versa. All right, kasi kidney function ma itong glomerular filtration natin. Pag pangit or pag meron tayong renal dysfunctions, mababa, decrease yung GFR mo. Pag decrease yung GFR, mag-accumulate yung creatinine sa plasma. All right, so this is the creatine metabolism. Glycine, arginine, and methionine by transamination will produce eventually your creatine. So with spontaneous reaction, it can be converted into creatinine. And also, creatine can be converted to phosphocreatine via creatine kinase, and phosphocreatine pwede siyang gamitin na high energy compound, and it can also be converted into creatinine. All right? And remember that creatine is synthesized in different tissues such as your liver, kidney, and pancreas. Okay, so what are the useful uses of your creatinine? First, it is used to determine the sufficiency of kidney function in conjunction with your other NPN, most especially your urea. It is also used to determine the severity of kidney damage. So, okay, ito yung base sa GFR natin sa creatinine clearance, which we will discuss later sa kidney function tests. Used to monitor the progression of kidney disease, again, with the measurement of your creatinine clearance or your GFR. And what are the specimen requirements? Again, just like in any other NPN, it can be done or can be measured in the plasma, serum, or urine. Okay, and as lahat din ng mga analytes natin, hemolyzed and icteric samples should be avoided, particularly in a Jaffe method yung ginagamit natin. And other than that, lipemic samples may yield erroneous results in some methods. So that's why non-lipemic na lang talaga yung gamitin natin. Okay. If meron man lipemic sample na hindi talaga, okay, we can use other methods, no? A fasting sample is not required, just like in any other NPN. And again, urine creatinine or urine should be refrigerated after collection or frozen if longer storage than 4 days is required. Okay, mas stable yung creatinine in the urine if it is preserved using physical methods, no, frozen or refrigerated. And here is the reference interval for your creatinine. And remember the conversion factor of your creatinine, okay, from milligrams to DL converted to SI 0.084, okay, and these are the reference interval. So different tayo, male, female, kasi nga it is dependent on the muscle mass. All right. Now, here are the methods of your creatinine. So creatinine, using the Jaffe reaction, creatinine reacts with the picric acid in alkaline solution to form red-orange chromogens. Remember that Jaffe reaction is non-specific, and interfering substances like ergothioneine and glutathione are found in the cells, which can actually cause derangement in the result. However, the Jaffe reaction can also be modified to different methods. So, pwedeng magawa ng merong adsorbent, okay? For example, itong Lloyd's method natin, Jaffe's test or Jaffe reaction with adsorbent. So, ito yung maganda kasi it is the most accurate method and thus known as the reference method. All right? So, creatinine in a protein-free filtrate is adsorbed into Fuller's earth or Lloyd's reagent and then eluted and reacted with alkaline picrate. So pag nakita niyo itong picric acid, yellowish yan, parang lemon yellow, no? Huwag na kayong magpatumpik-tumpik. Creatinine ang sagot dyan, all right? Jaffe without adsorbent, it uses PFF to react with alkaline picrate to form a colored complex or a colored compound. We also have kinetic Jaffe method, okay? Kinetic, pag sinabing kinetic at the rate between 2 time points, diba? All right. Creatinine mixed with alkaline picrate and the rate of change in absorbance is measured between 2 time points. Kaya kinetic siya. Okay, kinetic yung tawag doon, between 2 time points. And remember that this method is inexpensive, rapid, and easy to perform, and thus it is also very common in clinical laboratory. Okay, next is your Folin-Wu method. This is an adaptation of Jaffe, and it is less specific as it measures other non-creatinine chromogens like the following: vitamin C, pyruvate, acetone, and glucose. So therefore, hindi siya masyadong ginagamit. So for the sake of exam purposes, no, board exam purposes, pwede silang magtanong ng ganito. All right? Next is your enzymatic method. First is your creatinase CK. Okay? Remember, itong enzymatic methods natin, madami siyang enzymes na ginagamit, such as this one. 1, 2, 3, 4. Okay, meron tayong creatinase, creatinine kinase, pyruvate kinase, and LDH. And eventually, yung NAD that is produced, ito yun yung measure natin using photometrically. All right? Next is your sarcosine oxidase. Just like the creatinase natin, no? Apat din ang iya nga enzyme, no? Creatininase, Okay, creatininase, sarcosine oxidase, peroxidase. All right. Creatinine is converted to sarcosine, and sarcosine is oxidized to form glycine and hydrogen peroxide. The hydrogen peroxide liberated is used to oxidize a dye, which will convert it into a colored form. Remember that this is used in your dry chemistry, your Kodak Ectachem. Okay, itong sarcosine oxidase method. Okay, so dalawang creatininase, no? Apat na enzymes din, just like your creatinase CK. All right. Next is your other methods. Now we have the 3,5-DNBA. All right. And ito yung method, tandaan nyo ito, this method is adapted to reagent strip method. Although ang pangit dito is that yung color niya is less stable. Okay? Kaya kailangan siyang i-measure immediately. Okay? And also we have your HPLC. This is the most popular method that uses pre-treatment using TCA or trichloroacetic acid to remove protein. And it can also be used using chromatography, UV, and UV. Okay? So this is the recommended method, or recommended as the reference method to replace Fuller's Earth Jaffe method. Okay. Other than that, we also have the IDMS, diba? Measure can also be done or can also be measured or can also measure other NPN. We have the isotope dilution mass spectrometry. All right. And this is very specific. Okay, so increased concentration of creatinine is seen, of course, in your renal function, abnormal renal function, and in renal diseases. And plasma creatinine is a relatively insensitive marker and may not be measurably increased until renal function has deteriorated more than 50%. Kaya it is usually used in conjunction with other tests, such as your urea. Okay. Increased concentration of your creatine, okay, is present in your muscle disease, such as muscle dystrophy, poliomyelitis, hyperthyroidism, and trauma. Both plasma creatinine and urea creatinine are often elevated. So pag creatinine, more on the muscle breakdown or muscle metabolism. All right. So creatinine clearance. Remember that the plasma creatinine concentration, relative yung concentration natin makukuha dito because it can be affected by the muscle mass. Hence, different yung measurement ng male at female. The rate of creatinine turnover, okay, ibig sabihin, based on the renal perfusion pa din and renal function, all right? While your urinary creatinine excretion is constant, okay? Ibig sabihin, it can be used as a measure for the completeness of 24-hour urine collection. That's why na-develop itong creatinine clearance, which is a measure of the amount of creatinine eliminated from the blood by the kidneys, and glomerular filtration rate are used to gauge the renal function. So different stages yan kung ano yung value ng GFR. So very important ito for the clinicians. And remember that creatinine clearance will be discussed further in your kidney function test. So this is the formula. And again, this is multiplied by 1.73 because it is the standard body surface area per square meter. All right. So the last NPN, we have ammonia. Okay. So ammonia is formed in the deamination of amino acids during protein metabolism. So lagi nating naririnig itong ammonia pag may protein metabolism, urea cycle, okay, liberated yung ammonia, converted to urea, all right? It is removed from the circulation and converted to urea in the liver. So remember that ammonia is produced in the catabolism of amino acids and also by bacterial metabolism in the lumen of the intestine and from anaerobic metabolic reactions that occur in the skeletal muscle during prolonged exercise. Okay, yan yung mga sources natin ng ammonia. Okay, ano yung clinical application ng ammonia? So as I've mentioned earlier, lahat halos ng NPN natin is a measure to assess kidney function except for one kasi more on the liver function ito. So remember, ito yung mga clinical condition in which blood ammonia concentration provides useful information are the following. We have hepatic failure, Ray's syndrome, inherited diseases, or deficiencies of urea cycle enzymes. So lahat ng mga ornithine decarboxylase, etc., lahat ng enzymes doon pwedeng mag-affect sa ammonia or will increase your ammonia levels in the blood. The monitoring of blood ammonia may be used to determine the prognosis, although correlation between extent of hepatic encephalopathy and plasma ammonia concentration is not always consistent. Pero it is also used in the monitoring of your hepatic encephalopathy. Okay? So bakit hepatic encephalopathy? Meron kang liver failure and then the ammonia the ammonia is present in the system, okay? Nagkaroon ka ng encephalopathy secondary to the toxic effects of your ammonia. Kaya tinawag siyang hepatic encephalopathy. This is the site of injury, and this is the site of the effect of that injury. All right. Next is arterial ammonia concentration is a better indicator of the severity of disease. Okay. Kaya kasi ito, very prone ito, yung later we are going to discuss the specimen requirements. Kaya arterial pneumonia, better indicator siya, hindi yung venous kasi it's affected by pH then. And also it must be transported immediately and examined immediately, transported in ice. All right. Okay, what are the methods for your ammonia? So remember that the accurate laboratory measurement of ammonia in plasma is complicated. So very complicated, no? Parang relasyon yon ng jowa mo, all right? So bakit? Because it is very low concentration. It is due to its instability, okay? Pwede siyang agad kailangan mo ng ano ba siya? Social ba siya? Kailangan niya ng ice. I need ice to be transported. I need to be examined. Kailangan bigyan ako ng attention. So ganun siya ka-unstable. And also the ubiquitous nature of contaminants, because there are a lot of contaminants present, not just a patient, okay, but also within the lab, no? Tobacco smoke, urine and ammonia in detergents, glasswares, reagents, and even water. All right. Yon, yung problema sa ammonia. And with this, we have two approaches that have been used for the measurement of plasma ammonia. Ang una is that ammonia is isolated from the sample and then assayed, or it can be directly measured by enzymatic method or ion selective electrode, and it will detect the ammonia or ammonium ions. Okay, again, ammonia methods. As I have mentioned, Conway microdiffusion can also be used in other NPN aside sa urea natin. So ammonia is liberated by the sample by an alkali and quantified by titration or colorimetry. Okay, very laborious and poor accuracy and precision. Therefore, it is no longer used but for the sake of history of methods, pwede siyang tanongin. All right. We also have the cation exchange resin. This is followed by elution of the ammonia with sodium chloride and quantitation by the Berthelot reaction. Again, this is also laborious and time-consuming and cannot be readily automated. Although it has good accuracy, but it is now, hindi na din siya ginagamit ngayon. All right? Next is your coupled enzymatic assay, which is catalyzed by your GLDH, in which ammonia reacts with alpha-ketoglutarate and reduced NADPH to form the L-glutamate and NADP. Okay, this is the most commonly used method or automated in your instruments because it is precise and accurate pag-coupled enzyme reaction. All right, and lastly, we have your ion selective electrode. Okay, again, kailangan natin ng electrode in which the diffusion of ammonia through selective membrane into ammonium chloride causing pH change, which is measured photometrically. Okay. Although it has a good accuracy and precision, however, there are problems with regards to the stability of the membrane. Okay. So kailangan i-calibrate, kailangan constant yung pag-check ng calibration tsaka controls natin with regards to ion selective electrode kasi yung membrane very tawag dito, maselan, all right? Okay, what are the specimen requirements? As I have said earlier, very unstable si ammonia, so maarte siya, kailangan niya ng ice. EDTA, heparin are the preferred anticoagulants. So sila lang dalawa, okay? Venous blood should be obtained without trauma and placed on ice immediately. So kailangan niya ng attention. Si Mona, kailangan niya ng attention si Mona. Okay? Centrifuge sample at 0 to 4 degrees Celsius within 20 minutes of collection. Yan. Alright? Separated plasma is stable for 3 to 5 hours in ice bath while frozen sample is stable at negative 20 degrees. If you have ultra low freezer in the laboratory, for example, the laboratory is not capable of doing the ammonia test na kailangan i-send out, kailangan i-frozen siya at negative 20 degrees Celsius and transported also at least kailangan ng dry ice, right? Avoid hemolysis since red cell Since red cell has ammonia level of 2 times to 3 times that of plasma. So kailangan wala, non-traumatic. Alright? Pag merong any hint of hemolysis, repeat collection. Alright? Next is patients should not smoke because this is one of the contaminants, right? Smoke hours before blood testing. Alright? So dapat walang smoker sa ammonia natin. Okay, although ito, madaming mga substances, ammonium salts, asparaginase, barbiturates, diuretics may cause an increased ammonia in the plasma. And also, we have this one, no? Diphenhydramine. Okay, pag sinisipon ka, so uminom ka ng diphenhydramine. Lactobacillus lactulose levodopa can also decrease the value of your ammonia. All right, and also high glucose concentration can interfere in dry slide method. Okay. So ito yung specimen or ito yung conversion factor natin for your ammonia from microgram per DL to micromole per liters. Okay, we have 0.59 and these are your reference intervals. Okay, so increased concentration or hyperammonemia is seen in your severe liver disease. All right. Pag may problema ka sa liver na yan na yung hyperammonemia, hindi mo na siya nakakapag-produce ka ng ammonium ions in the plasma. We also have Ray's syndrome. Pag may problema sa liver, okay, hindi na nako-convert si ammonia into urea. Kaya mag-accumulate si ammonia. Same as your severe liver disease and Ray's syndrome. And also we have inherited deficiency of enzymes in the urea cycle. Okay, hindi ka makapag-produce ng urea. Okay, therefore, the substrate proximal to the site of defect or the site of enzyme na doon mag-accumulate yung products natin, which is your ammonia. Okay, lastly, so we have Ray's syndrome. This is a rare disorder that causes brain and liver damage and usually occurs in children who have had recent viral infection such as chickenpox or flu. Tapos yung nanay mo painom sa'yo ng aspirin to treat such infection. So yun pala, na-overdose na pala siya, yung bata. So nagkaroon siya ng severe liver disease. Okay, so ito yung Ray's syndrome natin. So pwede ka magkaroon ng hyperammonemia, prolonged PT, hypoglycemia. So meron kang liver disease or fulminant hepatitis and meron kang encephalopathy, which is actually very, very fatal if hindi na pagtuunan ng pansin. All right? So I guess that ends our lecture for NPN. Prepare for the quiz next week. Okay? And also included in the quiz are the assignments na hindi natin na-answer. All right? Thank you, everyone.